Hi guys, hope you're all having a good evening and thanks for joining us today for our national F1 tutorial on how to deal with common bleeps. It's been great to have you all joining in the stuff we've been doing, and we're really keen to share what we've got planned today. We're really excited to welcome the BMA today, who are supporting today's tutorial. Louise Cox and Rowan, who is an acute med reg. So thanks to both of you for taking time out of your busy schedules for being here. We will be moving on to the tutorial after the short 10 to 15 minute overview of what the BMA can offer. And I know that the support on offer right now is really essential for you as you start your careers. So I really encourage you to ask as many questions as you have. It's a great opportunity. And then we'll move onto the tutorial, which Yathu is going to take us through on how to deal with common bleeps. So without further ado, I'll hand over to Louise.
Okay, thank you. Hi all, the BMA is really pleased to be involved and sponsor the tutorial today. Welcome to this short presentation that outlines how the BMA supports you throughout your career. My name's Louise Cox and I'm one of the BMA's membership managers. I'm delighted to be joined today by one of our BMA reps, Dr. Rowan Gossage. Rowan is an acute med reg and is the chair of our Eastern Region Junior Doctors Committee, and he'll be on hand to answer any questions after. The BMA is working extremely hard at the moment to support doctors during the COVID-19 pandemic, and you'll have no doubt seen us in the press lobbying for PPE, death in service, benefit, etc. for doctors, and highlighting other challenges they are facing at the moment. How we support you. When you need employment, counselling or career advice, you can use our support and expertise to guide you. When an issue arises in your local area, our reps and advisors are on hand to negotiate better outcomes. And when it comes to health issues, we are the leading voice for change in your profession. Thank you, Rowan.
So you have junior doctor representatives at your hospital at a regional level and at national level. From a hospital perspective, we've had representatives across our hospitals sorting out investment in rest facilities and improving messes. When rotas have been more harsh than is acceptable, our reps have been there fighting for you to get that changed, and we've had notable successes across the region. From a regional point of view, we link into not just BMA committees, but also to other trade union. And during this pandemic, we've had regular meetings with the Dean to represent you to the Dean to enact changes and to support the system as we go through this. And from a national point of view, your BMA reps represent you to the GMC, to Department of Health and Social Care, NHS employers. So we're getting a lot done for you, and we are involved in a lot of different meetings supporting you going forwards. Your Junior Doctors Committee has had a number of successes over the last year or two. So we've had the big referendum that happened in July last year, which I was a part of, where we got more than 60 contractual improvements over the one from 2015. From shared parental leave that came in April of that year as well, increasing the support. And so shared parental leave in England has been enhanced to the same levels as occupational maternity and adoption pay, meaning parents can make a decision on what's based on what is best for them. We've led on the Fatigue and Facilities Charter, improving rest facilities for you across this deanery and across the entire country. And that's had a number of notable improvements and successes. And we're also trying to work, and we've also had an improved, we're improving the process on sharing your records across different hospitals. So when you move to another hospital, you don't have to go through the entire laborious process of medical HR sign-on. And that's on top of lobbying to do out-of-program pause, streamlining interdeanery transfer, lobbying for category 3 less than full-time training for those that want to do that later on. So we're doing a lot for you on many different levels. And I'll hand you back to Louise.
Thank you. We have over 230 dedicated advisors ready to help you at each stage of your medical career. And we're here to support you on anything from rotas, contracts and career planning, to ethics, fees, leave, pay, pensions, tax, and more. We've supported our members with over 5,600 employment contracts, 20,900 new member cases, and we've recovered over 17 million owed to our members in the last 12 years. Before you sign on the dotted line, get each new employment contract checked by our team of employment advisors. 20% of the contracts we checked in 2018 deviated from the national model. So whether you're starting a new job or changing roles, checking your current terms and conditions is vital. And we provide a free contract checking service to save you time and money. And our experts can check your contract, comparing it to the BMA's national model. Compliance with contractual rules is only one part of a well-designed rota. We've developed comprehensive guidance on the principles of good rota design to improve your well-being and safety. Our rota checker tool takes only a few minutes to check whether your rota complies with the English Junior Doctor 2016 contract. You'll receive your results immediately, and if required, you can be referred to a dedicated employment advisor to help you with the next steps. To help you pursue your learning potential, we have professional skills and career development modules designed to provide insightful and practical guidance for your career. Our webinars and masterclasses run throughout the year and cover topics such as medical CVs and application forms, career planning, workload and time management. Our library on dozens of ebooks and journals, plus research services, including expert dissertation support. And when we're in the middle of a pandemic, foundation doctors can also benefit from a free postal send and return service. You'll also get access to BMJ Learning, an educational tool built with evidence-based modules covering clinical topics, professional skills, and career development. And finally, our latest tool for junior doctors supports your research into medical specialities. Speciality Explorer can help you consider what you may not have otherwise considered and can help with making an informed choice. It's an online psychometric test which takes about 20 minutes to complete. Another really important service is our wellbeing support services. They are open 24/7 and are free of charge to all doctors and medical students. You can call and speak to a counsellor or take the details of a doctor who you can contact for peer support. So get started as soon as you join us. Get your contract checked with our experts ASAP. Look out for our emails to stay informed on political updates, guidance and resources to help you throughout your rotations. And if you need support at any to your BMA rep, an industrial relations officer and an employment advisor in your region. Keep in the know and follow us on social media. So many of you will be joining the workforce earlier than expected at an unprecedented time for the health service. We are proud of everyone playing their part to offer patient care during the COVID-19 crisis, and we want to make it as easy as possible for you to take on these new roles. For that reason, the BMA are waiving the remainder of your membership subscription fee for 2020, and you'll pay nothing until the 1st of October 2020, when we officially move you over to FY1 membership. For current members, you don't need to do anything to update your membership. All payments for final year students have now been suspended. And if you're not a member of the BMA, you can join online for free using the link on this presentation. So that concludes my presentation, and I just wanted to say, if you're at a trust in the east of England, which is my area, I hope to see you in the not too distant future, where I'm known for popping in with pizzas and donuts. And I hope you're all staying well and safe. And any questions for myself and Rowan?
Okay, so we have 3 questions. The first one being, what happens if I haven't received a contract yet for my FIY1 post? So you can, all FIY1 should be on one standard agreed contract that was done nationally by our by the JDC with NHS employers. So there shouldn't really be that much deviation. If you're concerned though, you should absolutely ask when you sign up, can I see my contract? Many trusts unfortunately do not give contracts out because they don't see the advantage to them. This is very frustrating, very difficult to challenge, but on asking your medical HR link, then they have to provide you with a contract. If you work in a hospital trust for 6 weeks without signing a contract, then by law it is taken as standard that you have accepted the terms and conditions that you're working under. So I understand that the next question, I understand that many doctors have been pulled up in front of managers and given warnings for speaking out against the lack of PPE during this pandemic. In scenarios like that, can the BMA help? And are they the first people to contact? So yes, absolutely, we are the first people you want to be calling in that situation, because quite frequently managers get far less vocal as soon as they hear that the BMA and trade unions are involved. You have to be careful about what you are saying and how you are saying it. So I would not be going, even me as an experienced trade union rep, would not be going on to social media and saying my trust does not have, naming my trust and saying it does not have enough PPE. But if a manager turns around and threatens you from a contractual point of view, then we are the people who you call to protect you in that situation. And like insurance, you get us before there is an issue, not afterwards, and we'll be there to support you. BMA is the same support, for contract checking available in Wales. Louise is the best one to answer that, but I can give a generic answer.
Yes, absolutely. All of our core products and services are available throughout the nations. So Northern Ireland, Scotland, Wales, yes.
So there are slightly different contracts across all of the nations, unfortunately. So England, Wales, Northern Ireland, and Scotland, and even Jersey have all got slightly different contracts. And we are there, to support, and we offer the same service for every single devolved nation. Do we work with physician associates? That's something that is being debated in many of our committees. At the moment, we do not, because we are a doctors' trade union and doctors' association, not a physician's associate. But that may change depending on how certain things get debated and voted through in our conferences. So my rota doesn't comply with the 2016 contract. I understand the BMA agreed to opt into working hours during the pandemic. Does this mean I have no rota rights? So this is a bit more complex. So as everything kicked off with the pandemic, a lot of trusts automatically just threw the contract in the bin and just wrote rotas which were in no way contractually compliant. We negotiated with NHS employers to curb some of the outrageous things that were happening. So we agreed for certain things that could be loosened during the pandemic only. And so during the pandemic is during the peak, and those were a set number of things which were publicized at the time, which I'm happy to share. But you do have contractual rights as soon as the pandemic is over, and you shouldn't really be still on a pandemic rota at this moment. You should be de-escalating or in a fixed area to de-escalate. Then yes, that's there. The breaches were for how many days in a row you could work, or so instead of saying 5 days, we allowed 6. In my own hospital, anaesthetists actually demanded to work more than 72 hours in a week, and that's what they wanted to do. So it's about mixing that altruism with not letting things go too far. But you do have contractual rights, and that will and all the old rules will kick back in very soon, but you still do have a lot of contractual rights at the moment.
Great. Thanks for that, Rowan. We've got some questions, some quick questions on Facebook. So Tanya's asked, what will happen if the BMA says that my contract is not compliant? What are the next steps to take?
So the next steps would be, it goes to our, so you would ring up our first point of contact or email, you'd then be discussed there. It would then get trickled down to our industrial relations officers, who are a bit like Louise, and they're paid members of staff whose sole job is to represent members across the region. They would then go straight to the trust and say, this is not right, you're in breach of contract. They would then have conversations with multiple members of the trust administration, and in the majority of occasions, a solution and compromise would be sought and fixed. In a very rare situation where the trust is being intransigent and they're in breach of contract, then we would then escalate this to an employment tribunal, which is a, I don't want to say it's a court, but it's a legal place where you go to an independent adjudicator to decide on what is right and what is wrong. And when it's a clear breach of contract, then we have a very strong record.
Great. I think thanks so much for providing that overview. And I was a BMA member myself for 10 years. I've really benefited by all the support that BMA offers, you know, whether that's through the library, through, you know, all the various kind of holistic support that BMA offers. I think it's really important, especially as you embark on your careers, that you take advantage of the support available. And I think it's great news that it's free to join as well, so you've got nothing to lose. Do you have any final words or thoughts that you want to share, Rowan or Louise?
Thank you very much for the opportunity, and we'll get out of your way and let you do your lectures.
Yes.
Okay.
Thank you. Thanks for the opportunity, guys, and good luck. Thank you.
Thanks very much. So we'll be beginning the tutorial now on how to deal with common bleeps. I'm really looking forward to this. I think it's such an important topic, and Yathu delivered a really great tutorial last time. So I think it's something that, you know, you're going to be thinking about a lot. I remember when I was just starting F1, I was pretty scared to kind of carry the bleep, and I'm looking forward to learning a lot actually from this. I've seen some of the slides and they look really good. So so thanks for joining us again, Yathu.
Well, lovely to be here, and thanks to Rowan and Louise for that talk as well. I'm not endorsed by the BMA, but I can attest that they are very, very useful, very, very helpful. Okay, so let me just get my slides up. Hang on, just bear with me. All right, share screen. There we go. All right, can everyone see that? Yeah. Okay. So what this talk is going to be about is common bleep scenarios, and basically this is just kind of what you can expect to have encounter on the wards. The content that I've kind of taken is based on what me and my colleagues experienced when we hit the wards. Kind of I got this from speaking to them and looking back at notes and stuff from F1, F2. So hopefully this is really useful to you. This isn't a substitute to your medical school lectures, but what it is, it provides context and gives you an idea of what you can expect when you are on the wards, what to do, who to call, and realistically how long things take when you are responding to those situations. Like I said in the last talk, when you get some of these scenarios in medical school OSCEs and you have to go through, you know, your A to E approach, etc. Often you'll rattle off your A to E in about sort of 5 minutes, and that'll be everything done. But in reality, it does take a little bit longer. There's things to do that interrupt your A to E. and also you might find that, you know, you need to get help, etc. So it's just to give you a more realistic idea of what's going on. As always, if you have any questions, fire away, that's absolutely fine. If there's something you don't understand, again, that's not your fault, that's my fault. I'm happy to ask the questions. I've got my email address up on the screen. So after this talk, or even during it, if you do have any questions that you don't want to put to the group or message me on Zoom, then you can just shoot me an email and I'll try to get back to you as soon as possible. And if I don't know the answer, then I'll either find out or point you in the right direction. All right. Okay. And this isn't endorsed by Cornflakes either, that's just me in my kitchen. Okay, so the general outline for the session is sort of the intro, which is now what I'm talking to you about, and then we'll go through 4 cases, and then there's just a bit more wisdom about being a new doctor. And some of you who were here for the last talk will have heard some of that wisdom before, but this is just kind of based on my friend's reflections on working life, and that's just a disclaimer as well. Okay, so case 1, okay, confused.com. Okay, so is that the ward cover doctor? I've got a patient here, Mr. Costa, who's 4 days post-op, seems to be really distressed, but he won't calm down. Please, can you review him? Okay, so I think the first thing is just take a moment to think about how you'd structure your approach to this patient. You've got this call, okay, to see Mr. Costa, who's 4 days post-op. Think about what more information do you need? What more information are you going to ask for the nurse on the phone? What structure are you going to use? And do you want anyone else there with you at this moment in time? Or who would you ideally think about escalating to, or calling for extra help if you need it as you approach this situation? So just take a few minutes. Okay, and if you want to kind of post on the discussion about any things, any thoughts you have, that's absolutely fine. Okay, so I think what a general approach, a good structure to have, and I tend to use this for pretty much any scenario that you're in, is firstly your A to E approach, which is your A, B, C, D, E, and we'll go into that in a little bit more detail. Then you want to get the history, which is basically finding out a bit more information about what is going on, what medications your patient is on, why are they in hospital, what comorbidities do they have, then your examination, then your investigations, and also your interventions, and also importantly, reviewing your patient, reassessing your patient afterwards and seeing whether what you've done has improved the condition that your patient is in. In this instance, we've got a patient who's 4 days post-op. He's quite distressed and he isn't calming down. So also think about some potential emergencies. So could you just take a moment now to think about, you've got a patient who's quite distressed. This could be some confusion. What are some potential emergencies, life-threatening conditions that can be associated with confusion in a patient? Yeah, good, very good. Perfect. And also, if anyone's kind of worried about posting in front of the group, you're more than welcome to kind of message me privately, sort of slide into my DMs. That's absolutely fine. And I'll try to respond to them as well. Good, got some good stuff coming through. Okay, lovely. So there's quite a few sort of potential things that this could be. I think in terms of emergencies, this could be due to hypoglycaemia. That's very good. It could be due to sort of a meningitis, encephalitis. Obviously, that's not high up on the differential right now for this patient, but always something to consider when someone comes in with some confusion. Could it be a bleed? Could it be an MI? Could it be that they've got low oxygen saturations? Always something to think about. So let's go through our A to E approach. So we went through this in the last talk as well, but it's always useful to go through this, and we'll come back to this as we go through the cases. So first of all, the airway. Can the patient talk? Is the airway patent? Are there any upper airway signs or upper airway sounds? that suggest that there's some airway compromise. Then if they've got a low GCS, you might be concerned about whether or not they've got a threatened airway, in which case it's really important that you go for help at that time, and then you may have to supplement their airway as well with an airway adjunct. Then moving on to assessing their breathing, their respiratory rate, their oxygen saturations. How much oxygen are they on at the moment, or are they simply on room air? This is a good time to do a respiratory examination to have a look and see whether they look like they're in any respiratory distress, and having a listen to their chest, assessing their chest expansion as well. Then their circulation, so their CRT, so their capillary refill time, temperature, are they cool and clammy, or are they warm and well perfused? And what's their blood pressure? And also what's their urine output? A poor urine output can be really indicative that a patient is very, very unwell. So always be aware of that. And also when you get to see, that's a good time to remember that getting access in the patient is always quite important, especially if they're really unwell. And then at this point, consider, are they going to need an ECG and a cardiac monitor? Moving on to D, assessing their level of consciousness, their GCS. We assessed it kind of when we looked at A, but it's always, remember to note that when you get to disability as well. Have a look at their drug chart as well. If it's a patient that's drowsy or confused, is there anything in their medication that might suggest or might be leading them or exacerbating this confusion? And don't ever forget glucose as well. So it was really nice to see that when we thought about potential differentials, hypoglycaemia was the one that came up straight away. And then exposure, so rashes, any wound infections, any other injuries. And later on, when we look at some other cases, we'll be looking at whether or not there are any drains and so forth. So that's kind of your A to E approach. Always bear that in mind. And it's kind of a really useful structure to have in your head when you're called to see a patient. And maybe you've been dealing with one thing already, and then it's a good way to kind of get you focused and work through what's going on with the patient. Okay, so Mr. Costa is yelling quite loudly on the ward, and because he is, and you can't hear any other airway sounds, you think actually, you know, his airway is quite patent. Respiratory rate's 18, okay, saturation is 98% on room air, and his chest is clear. His capillary refill time is less than 2 seconds, and their GCS is 14, okay, so slightly reduced, and his BMs are 6.4, so that's okay. If a patient is on oxygen, is there a rule for what their SATs should be? That's just kind of, that's what's come up. I mean, ideally you want your SATs to be kind of above, we'll say 94%. If you have someone who you put them on sort of 15 litres of oxygen and their saturation aren't above that, then that means something's wrong, because you are supplementing their oxygen as well. In healthy, you know, in me right now, you'd expect me to have saturations of 98% right now. GCS is the Glasgow coma scale. So that's when you're assessing them according to how their eyes are opening, whether they're moving their limbs, and also sort of their response to vocal commands, and also if they're vocalizing themselves. Okay, and it's out of 15. Okay, and just coming back to this as well. So E, there's no injuries, no clear source of sepsis, and no evidence of wound dehiscence as well, which is quite important in a surgical patient as well, because wound dehiscence, which is kind of when your wound is coming apart, one clear cause of that can be infection, and you might be wondering whether or not that's sepsis as well. Okay, that's fine. So, other things that you want to consider when you come to this patient at the bedside. You've done your A to E assessment, which is what we just looked at. Other things to consider. What else do you want to know? Well, you want to know what the patient's baseline is. At the moment, with a patient that's confused, we don't know whether it's delirium, so an acute confusional state, which is a really common and easily missed diagnosis, which is especially associated with the elderly, but also with patients in hospital. Delirium can affect any patient at all, and can often be just misdiagnosed as dementia. So you don't know whether it might be easy to assume that this patient just has dementia, but it could be delirium on dementia, or it could be delirium that's precipitated or driven by something else. So it's important to know what this patient's baseline is, and getting a collateral history is really important for that. How long have they been like this? Was it quite an acute change, or has it been a gradual decline? Do they have any other comorbidities, like we mentioned earlier? What medications are they on? And are there any clear precipitants in the history? So is there any evidence of a head injury? Have they had a fall? Have they been really unwell? Looking in the notes previously, have they been being managed for any electrolyte abnormalities? So it's really important to take all of this into consideration when you're assessing that patient. Okay. So let's go through some common causes of confusion. I've just sort of blown it by showing that next slide, but hopefully if you didn't get a look at it, do you want to just think about what some other causes of confusion could be? And we've mentioned a few already. Yeah, very good. Very good. Good. Someone sort of privately messaging me. Absolutely great. Perfect. Good. Good. Okay. So all really, really good suggestions. Pain, fantastic. Constipation, delirium, yeah, fantastic. Great. So again, this is not an exhaustive list, okay, but is some common causes of confusion. So dementia, delirium on dementia, some common medications that can cause, this includes pain medications, so your opiates, benzodiazepines, sepsis, if they're really acutely unwell, you can have that confusion as well, and also you might expect there to be a dropped GCS. Are there any electro abnormalities? And then these other two emergencies that we mentioned earlier as well. Okay. Yeah, deranged B12 on folate, good. Coming on to that next, actually, that's really, really good. So, first slide, what the bleep would you do? So, examinations. So, what you want to do is you want to get the OBS, okay? And this is stuff that you can ask for before you even get to the patient. So, once you've taken the call, you could just ask the nurse who you're speaking to, okay, I'm going to come along and see the patient. Could you just do a repeat set of OBS for when we get there? That's absolutely fine. Do a chest exam, do your abdominal examination as well. Maybe feel, see, is there any potential constipation, or is there any abdominal pain from around his surgical wound? Doing a neurological examination, is there any focal neurology which is accompanying this confusion as well? Any clear sources of sepsis, whether he's got any lines in. By lines, I'm talking about whether he's got any cannulas with fluids running in, has he got a catheter, central line, anything like that. They're all sources of infection and just things to be aware of when you're looking at the patient in that patient space. Is there any head trauma? And also it's worth having a look at the catheter bag as well. If the patient is catheterized, have a look to see, is there any urine? How much is there? And is that urine cloudy or anything that would suggest that there's a urinary tract infection, for example. Okay, so that's kind of what we're doing when we're sort of having a look at the patient, doing an examination. And what about some investigations? So what investigations would you consider? And again, rather than just saying bloods, think about what bloods you actually want, because in whether it's going towards tomorrow or whenever you're next in hospital, it will be you requesting these tests. So just have a think about what investigations you would want for this patient. Yeah, good. Very good, good stuff coming through. Okay, fantastic. So good. So it's really good when you're listing off those bloods, kind of, yeah, listing all of that. That's really, really good. So your full blood count, using these LFTs, TFTs, great. And we'll go into the coloured tubes as well, because that's quite important. So I've got the slide up there. So full blood count, you want your usines, your LFTs, your CRP, your glucose, calcium, TFTs, B12 and folate. So that's quite a thorough set of bloods there, but it's always worth being aware of that as well. If they're really, really unwell, or you're suspecting that there's some CO2 retention or anything like that, then it's worth doing an ABG. I think it's quite good to do a venous blood gas as well. If it's a patient that's very, very unwell, that's quite useful because it gives you a lactate as well. You can do a urine dip. An AMTS is very useful. And then during your examination, you don't have to routinely do your ECGs, chest x-rays, CTs, and LPs, but if there's anything that's suggesting that you might need to do those, then that's always a good reason to. For example, if the patient had, not in this environment, if they came in new and they had this new confusion, and you thought maybe that it could be due to meningitis or encephalitis, and a CT and an LP would be important, but we're not really thinking about that in this case. At the moment, what we have with this case, Mr. Costa, is a patient who's on a surgical ward who is slightly confused. But these are some investigations to bear in mind. Okay, so what the bleep do you do? So what can you do? Well, the first thing is it's really important, kind of not to medicate straight away. Being safe in this environment is also important. Confused patients can often get quite aggressive as well, just because, you know, if you're confused in a hospital environment, it's not the most natural environment. I think it would trigger a range of behaviour in everyone, really. So it's important to nurse them in a well-lit environment, and avoid restraints where possible. If you can speak to the patient, if you can calm them down where possible, that's obviously ideal more than that's ideal over anything else. Investigate and keep those broad differentials. So think about the list that we've gone through so far. We've been talking about infections, and we've been talking about some of the emergencies, electrolyte abnormalities, reviewing their medications, wondering whether or not there's a psychiatric history. Keep all of that in mind, because confusion is quite a vague thing for someone to have. Importantly, only use sedation if you really think that the patient is putting themselves or others at risk. And if there are any safety concerns, then it's absolutely fine to have security there with you as well. And they can be really, really good from experience. On nights, for example, it has been quite helpful having security there, but it's never really been an issue. When it comes to using sedation, so I've taken these from some guidelines, so haloperidol or lorazepam, and then if you've really excluded any serious causes, then zolpidem or diazepam can be used as well. But I think it's just important to note that don't routinely get into the habit of sedation as the solution when you're dealing with this on the wards. And it can be quite stressful when you've got someone who's quite confused, maybe aggressive, or sort of non-cooperative with you on the wards. And you're dealing with that at night time, but it's always better to kind of think about what the cause is and try and treat the cause where possible. Okay, so in terms of who else you can call for help, because it's not just you. You may think it's just you when it's you on the wards, but there's loads of other places you can go for help. So the nursing staff are fantastic. Are there any other F1s, other SHOs? In the daytime, is it Team Red or the medical registrar, that font of wisdom, the med-reg consultants? If you really fill out your depth and you feel you need more hands there, and you think this patient's really unwell, calling 2222, which is for an adult medical emergency, is also fine as well. And the important thing is, if you do feel out of your depth, don't be afraid to call for help, okay? Because the worst thing that you can do is not call for help in a situation where you should have called for help, and that patient deteriorates. Whereas if you call for help in a situation where someone turns up and says, that's fine, but you probably should have been able to deal with this, if you might feel a little bit bad for that, but don't worry about that. Patient safety is a priority, and if anyone's making you feel bad, it's on them, it's not on you. Okay, it's all about learning. So I had a slide in the last talk as well. You're not expected to know everything off by heart. Even when I was making this presentation, I looked at the guidelines, looked at resources, and that's important. So use Switchboard, trust guidelines, NICE guidelines, and when you start working, just know how to Mr. Costa might need caffeine. Very good. Just also note that there are trust guidelines, and just know where to find them on your intranet as well. Geeky Medics has also been very, very useful in F1. Even sometimes if there's things like forgetting what colour blood tubes you need for bloods, it can happen, especially if you're coming from not doing that routinely to being expected to do it all the time. So that's absolutely fine. Just know there's all those resources, and you're not expected to know everything. Okay, so going back to our plan. So just a review of the case so far. So just be aware, if you do have a patient who's quite confused, just think, is it delirium? And don't fall back on the default of assuming it's dementia. Have a look at their baseline. Confusion can be suggestive of a medical emergency, so just be sensitive to that. Is it a patient who's deteriorating? Are they very, very unwell? And if so, get help. And also just check the baseline, okay? Look at the notes, it's always important. Okay, fine. So on to case 2. sliding scales and arpeggios. That was me trying to be a little bit funny. I don't think it's worked, has it? Okay, so hello, you, the ward cover doctor. My patient, Dr. Davies, needs his sliding scale rewritten. Would you be able to do that for me? So, I mean, I can't see any of you at the moment who at this point in time is fairly confident with what a sliding scale is and would back themselves to be able to do that. I realize that no one's going to say. All right, great, cool, fine. Yeah, I mean, sort of 2 years ago, it was in exactly the same place. Kevin Willis, very nice, well done. Okay, good. But I don't want to do it. Okay, great. So we'll go through it because it is something that when I hit the ward, someone said sliding scale. It was a word I'd heard at medical school. I sort of used it in an answer once or twice, but I wasn't fully aware of what to do. But once you routinely get into it, it's really quite useful. So an insulin sliding scale. So a sliding scale is also known as a variable rate intravenous insulin infusion. Okay, and that's written as VR with 3 I's, not VR the third, as someone thought when we started work. So yeah, variable rate intravenous insulin infusion. You'll see that all over, and it's VR, III. That's fine. Now you know what that is if you didn't before. Okay, that's all well and good, but what actually is it? Okay, so basically what it is it's an infusion of insulin. Okay, so there's a drip of insulin. Okay, that goes into the arm or wherever, and the point of it is that you adjust the rate of that insulin infusion to keep the glucose levels within a specified range. Okay, now there are lots of reasons why you might use it. Okay, so it might be in a patient who's got erratic BMs, or a patient with hyperglycemia with known diabetes, who can't take oral fluid or food, who's nil by mouth, who's vomiting, or who's severely ill. What it allows is you to tightly control that patient's blood glucose levels. Now, the advantages of it are that you're targeting certain blood glucose levels and you get to stabilize them, and kind of you stop the BMs going up and down too much. Okay, and when I say BMs, what I mean is capillary blood glucose levels. Okay, and the disadvantages of it for patients is that you have to monitor their blood glucose levels quite often, which is not pleasant for them, and it may prolong their hospital stay. Now, for all the safety benefits of the sliding scale, there are some risks as well. So you can have hyperglycemia or hypoglycemia because you're giving fluid. As well, there's always a risk of fluid overload, and because you're giving glucose and insulin, there's always that risk of hypokalemia as well. So just be aware that for all the benefits and wonderfulness of the sliding scale, that there are some other downfalls as well. And also because it's lines, again, because it's intravenous, there's that infection risk as well. Okay, fine. So a couple of important points. So when I was sort of at this stage going into F1, I didn't know any of this. So this is kind of stuff that you learn as you go through it. On my surgical job, was doing it a lot. So this is kind of stuff to get used to. But don't worry if all of this is new. Okay. So firstly, you have to give the substrate solution, the glucose or the concurrent fluid, and the insulin infusion. You have to give it through the same cannula. You can put one of those octopus binectors on as well, but it has to go through the same cannula or the same line if you're giving it centrally. Okay, you shouldn't be giving insulin just unopposed. Okay, because there's a real risk that you can give someone a hypoglycemic episode, but there's an asterisk there because this may happen on ITU, but I'll kind of leave those guys to do that. That's fine. Okay, you continue the insulin infusion and substrate until the patient is eating and drinking and back on their regular glucose lowering medications. And just remember here, hypoglycemia can still happen when they're on this sliding scale. Okay, so and if they do have that hypoglycemia, which 4 is the floor, so a level of 4, blood sugar level of 4 is when, and below is when you treat them for hypoglycemia. So if that happens, then you treat them as hypoglycemia. And we went through that in the previous talk, but I've got those slides up here coming up as well. Okay, so just very quickly going over it, we won't go into too much detail. If they're able to swallow with BMs of less than 4, then you give 15 to 20 grams of quick-acting carbohydrate, and there's always a hypo box. If they're unable to swallow, then that's where you really need to get help. You need to get that IV access. You can give them 200 milliliters of 10% dextrose over 15 minutes. If there's no IV access, make sure help is coming, and then you can give them glucagon. Okay, just be aware for hypos on the walls. There'll be hypo boxes, which are essentially little orange boxes full of whatever you would need to manage the hypo. Kind of think about it as like a little snack box, but they're not for you, they're for the patients. Okay, so and that's what the box looks like as well. Fine. So this is just some common other causes of hypoglycemia, and we won't go into it in too much detail either. Okay, but you have those slides to do it. So let's get into it. How do you prescribe the sliding scale? Okay, this is the most important thing. Okay, so what you do is you prescribe the insulin first of all, which is 50 units of human act-rapid insulin, okay, added to 49.5 milliliters of 0.9, that should be percent sodium chloride, okay, so 49.5 milliliters of 0.9% sodium chloride, okay, just recognize that as the mistake there, sorry, okay, so that's one of the things you'll write on the drug chart, okay, and now you have to think about the concurrent fluids that you give, and that's the fluids that have the glucose in as well, because you don't want to be giving your insulin on its own. So what you can give, and this is taken from the Joint Diabetes Society for Inpatient Care, which is you can have 0.5% of NaCl or 5% glucose and potassium, either 20 millimoles or 40 millimoles. Now, that's not available in lots of hospitals. So the alternative can be 5% glucose with 20 or 40 millimoles potassium, or your NaCl with 4% glucose and your varying amounts of potassium, okay? And you can vary the amount of potassium based on what that patient's potassium levels are. If they are on a sliding scale, it's important to remember that you need to check their using these regularly. The potassium level is really, really important. As we mentioned before, because you're giving insulin and glucose, there's always that risk of having a low potassium. So just keep an eye on that and be aware that you'll need to supplement it, which is why in all of these fluids, you can give different versions with a different potassium levels, okay? And what that looks like on a drug chart is this, and this is, this is one that we wrote down in F1. This is what it will look like on the drug chart as well, okay? Right. So again, just some important safety measures to note when they're on the sliding scale. Regularly review the insulin infusion. Regularly review the need for them to be on this infusion, and also just be aware of fluid overload as well, okay? So with all things fluid, take care, okay? You want to be aware of fluid overload, okay? So with that, we're just going to kind of go into what you do with a fluid review. Now, I think with all things in sort of assessing the fluid status of a patient, what you want to be aware of is firstly, why are they on their fluids, why are they on their sliding scale, for example, and also be aware of firstly the input of fluids and the output as well. So all patients will have an input and output chart that will tell you how much fluid they've been taking, whether that's orally or because on their sliding scale, intravenously, and also what the output are, whether that's urine output, whether they've got any surgical drains, whether they've got a catheter, so that's urine output again, and also estimated insensible losses as well. And also when you're doing a fluid review, also be aware of whether or not the patient has any comorbidities such as heart failure, or whether they've got any renal pathology as well, because that can always increase the chances of a patient becoming fluid overloaded if they've been given more fluid than they're able to excrete, okay? So when you're looking at your doing your fluid review, an A to E approach is always very, very useful, okay? Again, we know about the airway. If you're looking at the breathing, having a look at their respiratory rates, has their respiratory rate increased? Is there any, are you thinking there may be some pulmonary edema? Do they have a listen to their chest? Have a listen to their lung fields. Do they have any bibos or crackles again, which would be suggestive of this pulmonary edema? Have a look at, listen to their their heart rate, their pulse, their blood pressure, capillary refill time. Their JVP is always a good indicator of fluid overload as well. Now, if someone is hypovolemic, okay, so they're depleting fluid, what you might expect is their heart rate goes up, their blood pressure might be low, Also, they'll have a sort of prolonged capillary refill time because it's taking longer to kind of perfuse. And also, you won't be able to see their JVP. In contrast, if they're overloaded, so hypervolemic, will they have a raised blood pressure, will they have a raised JVP, will there be crackles on the chest as well? Okay, and then we'll get to, I think very importantly is when you get to E, okay, and looking at sort of whether or not they're hyper or hypovolemic. Have a look and see, is there any pedal edema? So are their ankles swollen? Okay, is there any of that pitting edema? And you can test that by just pressing on their ankles to seeing if that's pitting or not. And also have a look and see if they've got any drains, any high output drains, how much is in the catheter bag. That's all very important. And also always have a look at the fluid chart as well. Okay, so it's really, really important that you consider these things. Okay, so just to conclude kind of this case so far. So sliding scales, don't be scared of them, okay, because we've gone through them and you'll be able to see these slides later with an example of how it's written up. If you are confused and if you find yourself on the wards and everyone's talking, they know what a sliding scale is, and you know, they're expecting you to just be able to do it and you're not sure, ask for help, because the worst thing you'd be able to do is to prescribe it incorrectly, especially when you don't know how. Every day is a school day, it's best to learn. So check your fluid balance, okay? You can have a hypo, that's a low blood sugar level when you're on a sliding scale. So 4 is the floor, treat a hypo as a hypo, and also review the need for that patient to be on that variable rate IV insulin infusion as well, okay? Okay, so so let's just go through what some of you guys have said. So glucogel, yeah, can be used. Yeah, it's not just an exam answer. How regularly should we check? So the CVGs, so the nurses will be the ones who are checking the blood glucose levels, but it should be hourly on the sliding scale. And that's, you always refer to the latest guidelines as well in your hospital, okay, and they are available on the intranet. And also, so we have the if statements, just going back to the slide. So what you can see is, and what we wrote here is, if the capillary blood glucose is greater than 12, so if they have a high blood sugar level, then what you do is you're giving them fluid without the glucose in it, just because that will help to slowly bring those blood glucose back down. And then once they're less than 12, then you can put them on the fluid where they've got that glucose in as well. So that's why you've got the if there, okay? Perfect, great. And that's what it looks like as well. And then normally you can give it, so that 125 milliliters an hour in a 1 litre bag, that would be kind of your 8-hourly bag. Okay. And also just be aware when you're doing your fluid review in your old frail patients as well, giving fluid very, very quickly is not wise. And also same for patients who've got heart failure as well. So case 3, low urine output. So we've got kind of a urine fluid theme, but that's a lot of what you'll be doing when you're F1s. Okay, so hello doctor, please can you come and review this patient? He hasn't passed very much urine, and also would you like a cup of tea? This does actually happen. Okay, the nurses and are lovely. They'll treat you really, really nice. Okay, so what do you want to know? I've kind of been too hasty with the slides as well. So what else do you want to know about a patient who you're going to assess who's got very low urine output? And we mentioned previously that actually low urine output can be an indicator that a patient is really, really unwell, because it suggests that they've got organ hypoperfusion. That isn't necessarily what's happening all the time, but it is something to consider. So in a patient with low urine output, what do you want to know? We'll just give you a bit of time just to kind of message. Yeah, catheter, very good. Yeah, eating and drinking, very good. Yeah, good. Obstruction. Is the patient catheterized? Yes, all really, really good, really, really good suggestions there. Great. Okay, we'll just give that 1 more minute. In fact, less. Okay, good. So cause of low urine output, as we've got on the slides here. So before that, what do you want to know right away? So is the patient catheterized? Very, very good. Do they look unwell? Is this patient not passing urine because they're very, very sick? Has it been a sudden drop in urine output, or has it been gradual? What's their renal function? And then going on to some common causes of low urine output. So hypovolemia is by far the most common cause. Other causes, you can break it down into AKI, and sort of very poor urine output could be a really, really severe AKI. And then your causes of AKI are just shown in the diagram here. We won't go into that too much. You want to know whether the patient's catheterized or not. Is the catheter blocked? Or is there any other cause, any other obstructive cause that's stopping their urine output as well? Okay, so Barry, so our patient, is catheterized. He's 6 hours post-op following a Hartmann's procedure. Okay, his catheter bag shows approximately 100 milliliters of urine. Okay, and you can see that on the input-output chart here. And that's since he came out of theatre. Okay, he is alert, he is orientated. Okay, he's complaining of some mild pain around his stoma site, but he doesn't seem to be in distress. And he is talking, he's alert. That's all quite good. So having a look at his obs, his heart rate's a bit raised, blood pressure, the idea if that was a little bit higher, temperature, he doesn't have a temperature at all, his oxygen saturations are fine, and his respiratory rate is fine. Now looking at his fluid chart, what doesn't seem quite right about the fluid chart? Not the fluid chart, the input-output chart. Yep, good. Yep, so that could be high stoma. Yep. Good. Yeah, and most importantly, it's the negative fluid balance. Okay, so temperature spike, is when it's over your 37.5. So if you've got temperature at 38.5, 39, then that's when you're thinking raised temperature. Okay, so this patient has had 500 milliliters of fluid. Has he got fluids up? Yeah. So this patient has had 500 milliliters going in, and also he's been sipping a little bit, just sort of 100 milliliters, just a tiny bit. He is post-op as well. He's not passed very much urine at all, and he's got quite a lot that's coming out of his stoma as well. So the concern here is that he's in negative fluid balance, okay? And so what we're going to do is firstly do the rest of the assessment as well, the rest of our fluid review, okay? So what else are you going to look for in your fluid review? So we've just spoken about it, and if you just post up some things about what you're going to look for in the fluid review as well. Yep, physical signs of hypovolemia, very, very good. His mental state, good. We'll do that full A to E assessment. We'll do the chest exam. We'll have a look at, listen to the lung fields. We'll also have a look at the stoma. Does it look like there's lots of output from that stoma? Have a look at the catheter bag. We've seen here that he's only got quite dark urine. It's a really small amounts. Does he have any fluids written up? And actually what you see is that he doesn't have any fluids written up, and he's got just sort of one empty bag that's hung up by the bedside. He's a gentleman that doesn't have any comorbidities, and his stoma isn't draining too much. When you assess his mucous membranes, you see that they are quite dry. Okay, so what do you do? Well, because he's hypovolemic, what you can do is start with a fluids challenge. So what you would do is you would give a bag, so like a 500 milliliter bag of normal saline, that's 0.9% normal saline, and then you give that quickly, and then you would reassess the patient. Okay, and hopefully when you reassess the patient, what you would notice is that the blood pressure has come up a little bit, the heart rate's come down, and you would assess to see whether or not that urine output has increased. If the patient's quite old, if they're quite old and frail, and you're concerned about giving 500, because that can be quite a lot, then an alternative is to give a smaller amount of fluid, so 250 milliliters, for example. But because he's hypovolemic, because he's dry, because his blood pressure is a little bit low, this is an opportune moment to give a fluid challenge. Okay, reassess. If you need to give another fluid challenge, that's absolutely fine. Always be aware and have the risk of fluid overload in the back of your mind as well. So if you find that you're giving large volumes, that's a really good time to phone your senior as well and just check, is this okay? Is there something else that we need to do as well? There can be kind of third space losses when you get into fluid balance as well, which is where you have kind of the loss of fluid into sort of the extravascular spaces in the body. That can be if they're very, very unwell, for example. So when you look at your input-output chart, it may seem that they've got an adequate input and an adequate output, but actually a very little of that fluid is actually in their blood vessels. So just be aware of that as well. Okay, so again, with your fluid assessment and your low urine output, check the fluid balance. Okay, be aware you don't want to fluid overload patients. If you feel that you're giving lots and lots of fluid, that's the time to discuss with the senior before you do that. With low urine output, it can be suggestive of serious illness. Be cautious in patients with CCF, so that's congestive cardiac failure or kidney disease. And if they are overloaded, so say this is a patient who does have sort of bibasal crackles, they're quite edematous in their lower limbs, then that's then consider diuretics as well. So that would be your furosemide, for example. Okay. And always, whenever you're in doubt, speak to a senior. Fluid balance is something that can be quite tricky, and the more you do it, the more you'll get used to it. And you'll kind of get a feel for when you're kind of eyeballing a patient and you're doing your fluid assessment, you kind of get a feel for what fluids you need to be prescribing. But it can be quite daunting going into it, so just to bear that in mind. Okay, so case 4, hematemesis. Now, this is something you've probably encountered quite a lot when you've been medical students, maybe in your acute cases. Okay. So we'll go into it. So you're writing up some fluids really, really well on one of the wards. When the emergency buzzer goes off in bay 5, you make your way up to the ward and find that Mrs. Jackson, one of your patients, has vomited up some fresh blood. Okay, and someone's pulled the emergency buzzer. What are you going to do? This is a situation that you can find yourself in. So what we're going to do is just kind of go through the steps of what you're going to do. We're not going to get too much into that the meaty medicine of it. Rather, what you can do as the junior on that ward, on that shift, at that time. Okay, so this has happened, this is the situation. What are you going to do? Yeah, very good. Good. A to E. Good. So you do your A, B, C, D, E. Good. The history, examination, investigations, interventions, and review. Think about your potential emergencies. So, this could be a situation maybe a couple of months ago, you think, what do I do? But actually now you've got a clear structure. You know what you can do. There's certain investigations you can get done. And even if it's a case that you're in the situation and you call for help straight away, in the time that it takes the help to come, there are still things that you can do for getting the extra data or just doing that assessment before the rest of the team come along. So there's always something that you can do, and just bear that in mind. Okay, so you do your A to E assessments. So Mrs. Jackson, she's alert and orientated. She tells you this is the first time that she's actually vomited this blood. Respiratory rate is fine. Saturations are fine in room air. You have a listen to her chest, absolutely fine. Blood pressure, 100/80. Okay, ideally we want it a little bit higher. And her heart rate is 110, so quite high. Capillary refill time, 3 seconds, and cool peripheries. Okay, so she's not perfusing great. And the ECG says sinus tachycardia, which kind of confirms what we've got with the heart rate, and there's no postural drop. Okay, it says PEARL here when we get to D. Okay, does anyone know what PEARL stands for? Yeah, very good. Good. Okay, and there's some epigastric tenderness. There's no bruising, so which would be indicative, and there's no blood on the PR as well. The reason that's in bold is that if someone is having sort of symptoms that are suggestive of an upper GI bleed like this, then you also want to do the PR exam as well. just get it done. Okay. So other things to consider. So I'm sure you're all familiar with all of this. So nil by mouth. If the patient is, if they've got low oxygen saturations, then administer oxygen straight away. Just be aware that there may be further episodes of vomit. Have one of those bowls nearby in the bedside as well. If you need help now, get help. And with this scenario, this is definitely a scenario if it happens that you are not expected to manage this on your own on the wards. Call for help, let a senior know, okay? You want to get access in this, okay, because this patient is bleeding. So IV access and resuscitation, that's fluid resuscitation, or considering a hemorrhage, considering a blood transfusion as well. And we'll just talk about transfusion a little bit later, okay? You want to stop, if they're bleeding, stop their anticoagulation, stop their NSAIDs, and consider antiemetics. And PPIs as well, okay? With these patients, the nice guidelines are that if they're hemodynamically stable, they need their endoscopy within 24 hours. But if they are hemodynamically compromised, then you want to get them to their endoscopy as soon as possible. To get your endoscopy, you will need to discuss it with a senior. So, for example, the gastroenterologist, that might be the gastroenterologist on call. Speaking to a senior colleague might be something that's quite daunting. Now, a lot of hospitals will say on their guidelines that it has to be a registrar that speaks to that senior, so your gastroenterology consultant on call or your gastro-reg on call. But you may find yourself in a situation where it's you doing it as the F1 or the F2 or the FIY1. I think like when you're requesting a scan, like a CT scan and speaking to a radiologist, don't be afraid of speaking to a senior. It's all about clearly communicating. So make sure you've got the notes, make sure you do a nice S-bar, make sure you have all the details down. And if you don't, just make sure you've got them within reach and just communicate quite clearly. If you find that the senior you're escalating to isn't responding to what you're saying, then it's absolutely fine to say, is it okay? Or I'm just going to get my reg to speak to you instead. Ultimately, what it is just clarity of communication and getting the message through to that senior colleague. Okay. When it comes to doing bloods, again, for this situation, when you're getting the transfusion as well, you want to do your group and save and your cross match. The way you do that is you're putting blood in 2 pink tubes. Now, as a standard, you have to handwrite these tubes. These samples need to be taken separately, so about half an hour apart, and you need to handwrite the bottles. The lab will not accept it if you stick a label on the bottle. It's been known to happen where in an emergency, someone stuck a label on the bottle and sent them down, they've been rejected, and they had to take the blood again. Let your seniors make the mistake so you don't have to, okay? So just make sure that you label those bottles by hand correctly, and also get a VBG as well, because you can get an HB on the venous blood gas quite quickly. Okay, with your IV access, that's 2 large bore cannulae. Okay, and you want to put them in a big vein, such as in your ACF here. Okay, and also if you need fluids, you need strict fluid balance as well. Okay. Just be aware that in this situation, the hemoglobin isn't going to drop straight away, okay? So just be aware you may need to take repeat blood samples just to fully assess the hemoglobin as well. And also just make sure that when you're doing blood, you're getting a clotting. That's in the blue tube that you have to fill up to a specific mark, because there may be some clotting discrepancies that you need to correct as well, okay? And when it comes to transfusions, patients, they're not routinely transfused blood overnight unless it's an emergency. So just be aware, if you are called to see a patient overnight and they are having a transfusion, just check whether or not, so in a different scenario, just check whether or not that transfusion is being given, just because it's been delayed from the daytime, and whether they need to have that transfusion overnight. And if they do, be aware that you need to go back and reassess that patient as well. Okay. Okay, and that's everything. So for the summary for what you're doing in this situation for the hematemesis, the main points are PR exam, just do it. You will need to discuss this patient with a senior. This is something that you escalate to. You may have to activate the major hemorrhage protocol. And if they are having a transfusion, then just remember that when you're getting the bloods for the group and save and the cross match, that it will be 2 separate samples, 2 pink tubes, and you have to handwrite the tubes, okay? And just as an additional point, clotting is very, very important in that situation as well, okay? So let's just have a look at some of your questions. Okay, so let's just go through it. So firstly, should we escalate to our senior or call the gastro senior? So first of all, escalate to your senior. So whichever team. So if you're the medical on-call team, then that's when you want to get, you want to speak to the med-reg at least, okay? They may then say to you, this patient needs endoscopy. Can you speak to the gastro senior, in which case you would go to them. But this needs to go through your, your senior as well in the team, okay? Two people, so a group and save. So they're two different tests. So the group and save is actually where you look at the antibodies on the blood to determine what that blood group is, okay? And then that might be stored as the sample on file, or the historical sample, okay? The cross match is where that blood is matched. That's another sample, and that sample is used to match that blood with the donor blood to make sure that the patient gets the correct blood, okay? So often you might find the terms kind of bandied around, kind of thrown together, and so you kind of go through working life thinking group and save cross match is one phrase, which I'll admit have done in the past, but they are two separate tests, but often when you're doing them, you will just kind of do them groups together, okay? So that's kind of the four summary, so the summary points for the four cases that we've looked at. There are lots of other scenarios that we couldn't really get through in this talk, but there's a list of other common bleep scenarios that I'll put at the end of these slides, and someone will be able to go through them with you at some point. I thought what we'd use the next sort of 5 minutes to do is just kind of go through just a bit more wisdom now. Some of you may have been or tuned into my previous talk week before last, but so it is going through that same wisdom again, but this is really just some of my reflections and my friends' reflections on what it was like starting work and what you can kind of do to kind of take, to kind of be kind of less scared about going onto the wards and kind of be a bit more at ease, okay? So, firstly, so there's case 5, which is the medical students, or the FYI ones who became brilliant doctors, and that's all of you who are listening. So, firstly, you will become a better doctor by trying to be a better doctor, by which I mean, the more you try to get stuck in, the more you get involved, the more open you are to learning, the better you'll be, the more experiences you have. Ultimately, someone told me, and this is really useful, your experience informs you. So kind of the more you experience, the better you are, the more questions you ask, the more you know. Don't be afraid of asking questions. The only silly question is the question that you don't ask, okay? You know, you'll be working with colleagues who've been in hospital for years, so just don't be afraid of coming across a bit silly. There is so much wisdom in a hospital from everywhere, from all the specialties. So just get stuck in, ask questions, okay? Have something to look forward to outside of work. So whether that's hobbies, whether that's playing golf, playing football, you know, whether it's reading, whether it's whatever it is, have something that you look forward to that isn't medicine, that you can just do to switch off, okay? Talk to people, talk to your mates, talk to your family, talk to them about things that you see at work, but also talk to them about things that don't happen at work as well. So life isn't just all about medicine. A cup of tea fixes most things. A cup of tea and a custard cream fixes all things. But just importantly, just look after yourselves, okay? And then just take the time for yourself, okay? Be organised. So that's something that's easier said than done. I think everyone, you know, your mums, your dads, my mum is telling everyone just be organised. What does that mean? Well, that can mean lots of things. For me, it's kind of when you do a ward round, stepping back at the end of that ward round and making a list of all the jobs and allocating those jobs to everyone, and then arranging to regroup later to make sure that you've got through all those jobs. Okay, but being organised doesn't just apply to work, it applies to your personal life as well, okay? So it's going to take a while for you to get into a routine once you start working. And, you know, whether it's juggling when to do your laundry or when to do your food shop or when to phone your mum, etc., etc. It's quite difficult, but you will fall into a routine eventually. Going into work with damp socks, it happens to everyone, just accept it's going to happen. It happens to some people more often than not. Absolutely fine, but there's ways you can get around it. Sometimes you might find that you take sort of 5 minutes, 10 minutes at the beginning or the end of the week to kind of say, I'm going to do my food trip on that day, I'm going to do my laundry on that day, and that way I'll have dry socks for when I'm back at work, and I'll have a full fridge. So just do that. And that's kind of what I did to kind of get through it. And I think finally, be kind whenever possible. It's always possible. So I think in a hospital, there's lots of stuff going on in the hospital. There's lots of quite extreme situations, and it can kind of get to you, can kind of wear you down. But that doesn't mean that the hospital has to be a horrible place to work, because, you know, if you're kind to your colleagues, if you speak to your colleagues, if you support each other, it can be a really nice, enriching place to work. So just be kind to your patients, be kind to your colleagues, and everything will be fine. Actually, you'll enjoy going to work. Thought damn socks was going to be about getting PP in your shoes. I mean, yes, you will also get damn socks from weeing in your shoes. Hopefully not from you weeing in your shoes. But yeah, so again, it's going to happen. It's going to happen. Okay, so that's kind of the summary slide from the talk. If you have any questions, kind of post them up now, and we'll kind of go through them. Alternatively, my email address is coming up on one of the slides next, so feel free to shoot me an email, and then we can kind of go through bits and pieces as well. Okay, so I've got some questions coming up. Okay, got some things coming up here. Cool. So, right, so as always, there's going to be a slide that comes up with feedback. But before we get there, this is a list of kind of common bleep scenarios that can come up. Okay, all really, really useful. We've gone through the ones that are in bold. And then on the previous talk, we went through falls and collapse as well. Okay, my email address is here. So if you've got any questions, you can always send me an email. That's Maheswaran, that's me, at doctors.org.uk. Don't feel weird about it. Just send me an email and I will reply. That's absolutely fine. Perfect. Great. And these are my references. So for kind of talking about the sliding scale, I looked at the Joint Diabetes Society for Inpatient Care, which is really, really good. It's quite a good guide to go through, actually, just because when it gets to managing blood sugars and fluids, it's quite tricky. And also the Oxford Handbook for the Foundation Programme, which is this book here. I found that really useful kind of in going through F1, F2. It's not for everyone, but I think it's quite a good summary of kind of things that can come up. Yeah, so it's really, really useful. And it's got some good sort of wisdom in there as well, just about juggling other things as well. So, you know, when you're coming up to interviews or doing audits and things like that, because it can be quite a lot. So that book's quite good. And finally, feedback. So what these guys are doing, the Becoming a Doctor team, is really, really great. Thanks for giving me the opportunity to talk to you guys. And if you guys fill out the feedback form, that's useful for everyone. Be honest with your feedback. It's fine. My tears will dry. It's absolutely fine. Okay. And we'll just go through some questions now, just before we end. Perfect. Okay. Okay. Any other questions at all? It's turning to Q&A about me. What specialty am I interested in? So I'm interested in anaesthetics. That's what I'd hopefully like to go on to do. What I'm doing next year is doing an F3 in New Zealand. Hopefully that should still be going ahead, but just sort of keeping an eye on that, just with the kind of ongoing COVID crisis. But anaesthetics is the one. But I'm also interested in kind of med ed. That's kind of why I'm here, and kind of global health stuff too. Okay, great. Well, I'd love to go to New Zealand. All the best, but thanks very much. Cheers. Cool. Any other questions? So I'm sorry this went over the 8 o'clock clap, but sort of this is for all of you guys when you hit the wards. I'm sure you absolutely smash it. As always, if you've got any concerns, just talk. just talk to people. There's kind of nothing that can't be sorted out with a good chat. Oh, someone just sent me a question. Oh, someone just said, would you say it's better to work abroad before F1 or after? So my advice is to do your foundation years first, and then go working abroad. So, because with the foundation year, you get that's your time to get used to working in the ward environment, working with other people, getting used to managing unwell patients, and kind of going through all the competencies that you need for F1, F2. So my advice is do your foundation years and really get stuck in, really get to grips with the wards and how things work, how to react in situations before you then sort of move into potentially unfamiliar environments abroad. How do you deal with a mean consultant? Okay, so I think it's not a certainty, but I think just because of the way that it's structured in medicine, you have sort of senior colleagues with a lot of experience, and you can coming into it quite junior, and so you were relying on their experience. You may find that you're kind of on the receiving end of some quite curt words. Sometimes it's not intended like that. It's just a byproduct of it being a very fast-paced environment in the hospital. So, if you feel that you're not getting recognise you feel that you're getting quite sharp feedback. Sometimes it's not intended like that. However, that said, if you do find that you genuinely feel like that what's been said to you is not appropriate, and actually it was mean or it was unkind, then there's lots of people you can speak to. First of all, kind of speak to your other team members, so speaking to your other F1s. And that support network is quite good. You can speak to the reg in your team if you think that's something, and also bear in mind that you can speak to your educational supervisor is one to go to, or your clinical supervisor as well. But I think the main thing is just I think the main thing is just make sure that when you're responding to that mean consultant, you do speak to someone that and you kind of speak to someone that helps you through that kind of emotional phase that's caused by them being mean. How do you prefer for being my senior doctor on the ward on night shifts? Okay, so I think for night shifts, so you may be the most senior doctor on the ward, but you won't be the most senior doctor in the hospital. Okay, so just I think be aware of who you can escalate to, whether that is the reg on call, or if you're doing it works, changes in different hospitals. If it's a surgical specialty, sometimes it's that surgical reg who, for that specialty, he may not necessarily be on site. So just know who to contact and when to contact them. I think the most important thing is if ever you fill out your depth, you're not comfortable, or you need more hands, or you need more help, just call for help. That's the most important thing. And don't be scared to do that. That's absolutely fine. And ultimately, just trust your judgment as well. Not to worry, that's fine. Cool. Okay. Well, if there are no other questions, then we'll call it a day there. But as always, fill out the feedback form that's up here, and you can send me an email at Maheswaran@doctors.org, and I'll try to get back to you as soon as possible, or point you in the right way. Thanks to the BMA who gave their talk at the beginning of this, and also thanks to the Becoming a Doctor team. You're doing a great job. Take it easy, guys. Bye.